Good morning, Las Vegas. It's Zandra Pollard with It's Where I Am. Today we have Women Empowerment 2022, Part 2. So now we have our panel of mental health professionals. So we have Dr. Deepa Hasija, Dr. Gwendolyn Green, and Dr. Althea Cook. So they answer questions from the audience. We also discuss how to understand if your loved one or yourself needs professional help. And we also want to make sure that we are acknowledging Sluggin' the Magazine, who is our proud sponsor. So thank you 91.5 Jazz and more for tuning in to It's Where I Am. I'm here every second Saturday of the month at 8:30 a.m. And don't forget, stay tuned for our Women Empowerment Conference Part 2 on my website, itswhereiam.com. It is Women Empowerment 2022. We have a second panel here today of women who are actually experts in the field of mental health. We have a psychiatrist and we have two doctors of psychology. So please be prepared to ask them some questions, because I know a lot of us are having a hard time getting through. We do have telehealth, which has made major accomplishments not accomplishments, but has given opportunity to people who have not been able to get help before. It has also gotten people who need help that have a difficult time getting out the door to get help, because that's an issue, to get therapy right at home. However, it's made it very difficult for the professionals to keep up with all of the demand. Okay, so that's why I brought these women here who have spent most of their day here with us. So please make sure you ask. Ask. Okay? Thank you. So ladies, can you come out, please? We have Dr. Gwendolyn Green, Dr. Deepa Hasija, and we have Dr. Althea Cook.
Hi, everybody.
Hello, I want to thank you ladies so much for being here and being patient with us as we're going through our first Women Empowerment 2022. The focus is obviously mental health, because my show concentrates on mental health and wellness. So again, thank you for being here. I want to start by thanking you, Dr. Hasija, for bringing the team together.
So I know for myself, as a clinician and marriage and family therapist, the first thing I want to know is a little bit more about your family dynamic. So what's going on in the home? Has something changed? Reach out and find a provider that's covered so that you can go and get services. Most insurances will provide you with a provider directory that will give you names and locations of child psychiatrists, child psychologists, and people who can actually help you to get the appropriate assessments and such done. Then at that point, once they come in and they see like myself or Dr. Cook, we might decide, well, okay, this kiddo has a little bit more going on than what we would normally treat with just individual therapy or family therapy. And at that point, that's when we make referrals to Dr. Hasija or a psychiatrist who can further assess and determine a pharmacological approach for the child.
So did you want to add on to that, Dr. Cook?
Yeah, so like Dr. Green mentioned, it's a lot more that goes into it. But for the basis of this question, we kind of just start with the primary care physician, and then if you need a referral, you'll go on to see a therapist or what have you. And then, like we said, medication is always a last resort, and Dr. Hasija can talk a little bit more about that. But what we do in the process is kind of trying to figure out what is going on with this kid and what services and what support the child needs. Okay, and there's a number of resources here in Las Vegas that can aid in the support that the kid they need. So we're kind of like treating the whole person, not necessarily one specific area. Unless they're in foster care or something like that, we do need the parents to sign off and be involved in the treatment. Like we say, you know, you may treat the child, but they're going back home to the same family they live in, and a lot of the challenges occur. So there are different types of treatment interventions that include the family. Most treatments for kids involve the whole family. Okay, so the kid can get individual therapy as well as do therapy with the parents as well.
Okay. I just wanted to point that out because it's such an important piece to the therapy, you know, because I've been on the other end, and I've listened to parents say things like, well, why do I have to be there? Because you're a part of why they're there, period, right? Yeah. So I just wanted to make sure I got that out there. Dr. Nasija, how do we talk to parents about understanding that it's okay if they need a little bit of help? Because we can put on a Band-Aid, if our leg is broken, we can get it gassed, but we just won't accept that when our brain needs help, we need a little bit of medication. And we'll take a Tylenol. If I have a hangover, I don't have a problem taking a Tylenol. You're getting into drugs that we don't know about. So that can be scary. So how do you open that conversation up with parents for them to understand that it's something necessary for the child?
So first I'm going to say that, you know, most people have this perception that psychiatrists or child psychiatrists are there just to start medications right off bat, which is actually not true. Child psychiatrists specifically, our goal is to first talk to the child, talk to the parent, and understand what's going on. Medication is absolutely a last resort for us. So when a child comes to see me, I usually say, okay, is this a school issue first? Is this a family issue? We go back to, let me refer to the school first. Schools have counselors. That should be the first line. When kids go to school, they're at school majority of the day. So the teachers are seeing a lot of these behaviors firsthand. When they come home, they spend partly time there. So the parents are noticing things. We have to get a holistic view of things. What happened with them as terms of, are they sleeping okay? Did something change in their diet? Did something happen with grandma? Or did something happen with dad that's kind of changing the system? So good history is very important in this. And the only way to get a good history is to listen to different parts of the team, which is the parents, the teacher. The child is the most important. If you sit and talk to the child and think about things from the child's perspective, a lot of your answers are right there. So when they come to me, we actually take a step back and say, let's listen first. Let's listen. Let's refer to therapy first. We'll refer to therapy for 12 weeks. We'll coordinate with therapists and get feedback. What is going on with this kid before we even consider medications. As far as child psychiatry is concerned, we do have to do that first in order to even say, you know, we're recommending medication. Because medication is the last resort. Nobody wants to put any child on medication. Sleep is very important. Sleep is a big question we ask about. How is your child sleeping? If adults don't sleep well, we don't act right. So we can't really expect kids to act right if they're not sleeping well. Or if they're not even eating well. That's a big part of it. And then feedback from the teachers is extremely important. How the kids behaving in school versus how the kids behaving at home. A lot of the story will come right from there. If someone does need medication, I'm not saying we won't start it. In some situations where the child is acting completely different, like if weeks have gone on, they're not eating, they're not sleeping, we will refer to the pediatrician first. We'll get blood work done to see if something's going on before we come to psychiatry. So things have to be ruled out absolutely before they come to psychiatry. If something is needed or the kid is hurting themselves or hurting other people or doing something dangerous. For example, like a 7-year-old is so hyper that when the mom says, when we get out of the car, please look on both sides, and the kid's not able to do it, they're just running into traffic, doing something that dangerous, we would treat something like that. You know, we obviously don't want any child to get hurt and not treat them.
You can go ahead and clap. So I'm going to let you guys ask questions now because we're going to talk about the children, but as I'm understanding, you guys deal with adults as well. And so I want to try and get some of my therapy questions out. So let's start with the children. Any questions about children?
I'm in child welfare, so I know you guys do the acute services for our kids. And I'm just wondering, what are some of the challenges that you guys find with, you have repeat kids that keep coming back? You know, these parents don't have maybe the right insurance or anything else like that. What kind of advice do you give a parent who has those struggles with probably not having the right insurance or not having the right supportive services, like access to that? Because I know that in our city, we don't really have a lot of mental health services that really support our kids. So what are some of the advice that you give those parents?
So some of the advice that I give is, I do work for DCFS as well, and they do offer, for kids who are not insured, they do offer mobile crisis services. They also offer, with some of it is in-home service, as well as therapy. We do have telehealth for them. Even medication management is actually covered free of cost for those kids. So educating, you know, the community on that we do have this resource.
And I'm going to add to that what Dr. Placebo is saying, because I too work at do some stuff at DCFS as well. And one of the challenges that I see with kiddos that come into our residential treatment, and you know, they spend 6 to 9 months with us working on behaviors, working on their psychiatric concerns, and then we discharge them and go home. One of the biggest challenges that we see is that there's no continuity in the home. So a lot of the things that the child has learned while they've gone through treatment kind of starts to fall off when they get home because, you know, maybe mom and dad are too busy to, you know, do the redirections that we teach or to hold the youth accountable or to actually go in and make sure that they made their beds and done their chores and everything like that. So one of the things I always try to impress upon the families as we discharge a youth back into the home I try to give them things and tools that they can use in the home so that they can continue to see those behaviors that we saw in treatment with the youth when they get back into the home. You know, it feels more familiar for the youth, right? Because they've spent 6 to 9 months learning these skills, learning how to be responsible, learning how to be respectful, learning coping skills so that maybe they're not self-harming when they get upset or they get really sad. And so, you know, one of the things we want to make sure happens is that the parents have those tools that they can use with their youth in the home.
Well, Desert, I know that Desert, like Oasis used to do that, and you guys have taken over for Oasis. Oasis has moved over to Desert Willow now, right? Or Desert Parkway, not Desert Parkway, but
yeah.
Right? Desert.
So there's been a transition.
So they used to do that with parents and do that training with them throughout the time that the child is there. Is that happening there now?
Yes. So yes, and so what you're referring to is within the state of Nevada, because we do have challenges with our mental health services that are available for our kids, but we do have 3 behavioral issues get help with their psychiatric issues. And so the one in Southern Nevada was named Oasis, and that's exactly what we did. A big piece of it was really that parent education and parent training that we did as a part of the component of the program. That particular PRTF is demising, and everything is transitioning over to Desert Willow Treatment Center, which is the only state psychiatric facility, state-run psychiatric facility for youth 12 to 17 years old. And so still a big part of that program is that we're meeting with the parents every week, and we're talking about the behavioral changes that we see with the kid while they're in treatment, and we're talking to the parents about what they're doing. You know, are they working on themselves, right? Because sometimes, you know, mommy and daddy got some things going on too that they need to get some help on. So we want to try to make sure that they have access to the appropriate resources so that they're doing some work too, while we have the kiddo in treatment doing some work, right? Because it doesn't help to send them back to a dysfunctional system. Because no matter how many skills we give them, if you put them back into a dysfunctional system, there's going to be room for failure. But to your question, yes, we still do parent training. We work very closely with the parents. They're expected to participate in weekly family therapy sessions. They're expected to call their child and talk to their child on a daily basis, right? Just because they're in treatment with other people doesn't mean that alleviates you of your responsibility of parents. So we try to keep the parents very much engaged in treatment.
I wanted to add a little bit too. So with all these things that we're talking about, it's really important that there's patience in this process. You know, there's no one treatment that fits all. You know, all families are dysfunctional, and it's a whole process. So, you know, the aftercare services that are provided to the family should definitely be taken serious and continued care after that point. Because just for the child being in a facility is not going to fix, or it's not fixing type of situation. It's just trying to help the child get some skills that can help them, okay? And then this is going to be like a lifelong. When I do discharge planning, I try and address families like, this is something, these skills, we want you to incorporate. Well, really for the rest of your life, you're gonna need them, right? And so it just takes patience in the process and, you know, like a lifelong commitment to it.
In the younger ages, elementary level, a lot of training is done on ADHD. On the older levels, there's a lot of talks on suicide, how to look out for the signs of suicide, depression, if someone is cutting, if they have marks on them. So the system, the teachers are more aware now, and they are more trained on it. I'm not sure how many hours they do per year, but I know for sure they are trained on behavioral issues and depression, anxiety, how to look out for signs of suicide, or if there's a very significant change in behavior, they do reach out to the parents and see what's going on. As far as psychiatry is concerned, child psychiatry, if the parent signs a release of information, we do contact the school, and the school counselor does give us information on how the kid is doing in school. There's also IEP programs where you can say, I want a therapist to go to the school. I want them to observe the behavior in school and also observe the behavior at home. And some agencies are doing that.
We have a question over here.
Yes. What would you suggest for the tired parent who has exercised talking to the medical doctor, has gone to a therapy referral, has put their child in with a therapist, and then they turned out to be the kind of therapist that just listens and doesn't have any suggestion, and you don't realize until you sit here at the Women's Empowerment panel that that's what you're experiencing. And there is no help from the school because the main abuser was the school. The counselor that you asked to speak with never called you back, and now your child's homeschooled. Where would you suggest that person, that's me, to start?
I would say that, that's an extremely hard position to be in. And to be honest, I hear that a lot from a lot of parents. So we did dig a little deeper, and the issue is our community is strained for resources. The school is also extremely overwhelmed. The teachers have a lot of responsibility, and teachers are a lot of them are extremely good. The counselors are good, but they're spread too thin. Okay? And if someone is tired, it's an issue that's become more prevalent right now, especially with COVID times, because the child is at home. The single parent can't really go to work if the child's very young. Someone has to monitor that kid being online. So a lot of single moms have actually had to quit work and be home just so that their kid can attend the online classes. So I think in general, all of us, everyone is struggling it's a very bad situation. I would say, you know, friends, family, people who can be positive and support you, you know, reach out for that help. I'm struggling, but reach out to your family member and say I'm struggling. And they might say, well, I'm struggling too. I can't help you. Find someone that you can get together with. I have realized, especially in this pandemic, that people do want to help because everyone's come into the same boat almost. You know, we're needing each other. As humans, we realize we are vulnerable during this time and we need each other. So to reach out for that help. And if you do need to take it to a level where someone is really needing help, you know, take it to psychiatry. Let that kid talk to somebody. Unfortunately, the resources in this community are limited. You know, I do realize that working in this community, talk to friends. You know, I would say there are people out there. You just have to tell them, I need help.
Don't forget about your own self-care. And just with regard to, you know, you said took them to a clinician and all they did was, you know, the very Rogerian, just the talk therapy, tell me about your day kind of thing. So, you know, especially when you're dealing with your kid, you want to make sure you research as much as you can the person that you're taking your child to go see. So try to see what kind of expertise this person says they have, or what type of population they're accustomed to working with, right? Is this a person that just primarily treats adults, but they see a kid here and there, or is their practice primarily geared towards treating, you know, children? Because that's going to make a difference as well when you start to look at the modalities that are used to approach the care of your child, right? And then two, as a parent, be very involved in the care, you know, expect to see a treatment plan. You know, you want to know, okay, what are you going to do to help my child with these specific concerns that I've brought to you? What I try to do in my practice is when you come in as a parent, my first session is with you. I want to meet with the parents. I want to know what your concerns are. I want to know what you've seen.
Without the child?
Yes.
Yeah,
absolutely. Yeah, because I want you to be able to speak freely. I want you to be able to exhale, get it all off your chest, and let me know what a lot of your primary concerns are. And then the next session, you know, the first, depending on the age of the child, the first, you know, the next 2 or 3 sessions is you and the child in the room, right? And then I start to wean you out of the session and it becomes individual with me and the child. And then I might bring you in later so that we can talk about, so that your child can tell you what they've learned and what they're going to do at home. So that everybody's brought into, okay, this is the behavioral change I expect to see at home. And you can hold the child accountable, right? Because I need you to be those eyes and to be that person there, kind of remind, you know, kids forget. They forget from the bedroom to the kitchen, right? Oh, I was supposed to brush my teeth in between there. So, you know, it's important. The family plays such a big role in the care of the child. And, you know, it doesn't have to be family in the traditional sense of mom and dad. It can be your extended family, cousins, nieces, uncles, aunts, fictive kin, right? So that play uncle that comes over and takes your son out to go do cool things. Everybody, it takes a village. It really does, you know? And so the goal is that once you start learning the skills that the therapist is teaching your child, is that you share that with everybody else so that you say, hey, if you see him doing this, correct him. Yeah. And remind him what his therapist said, because when he goes to see the therapist next week, she's gonna ask, how were your behaviors? How did this go? What did you do? And hold the child accountable. So all of that plays into how effective therapy is gonna actually be for a child, I think.
I wanted to add one thing too, because I worked for 5 years within the Clark County School District, and I'm not sure you guys are aware, besides the counselor in every school, there's a mental health professional there, okay? And that mental health professional, yes, in every single school. And so they're adding extra resources to things that the kid can have in each school. So when I worked for the school district, I will do self-esteem groups for girls, and I'll do a self-esteem group for the boys, okay? As well as work with psychiatry, therapy outside of the school system, work with the IEP, evaluator, work with the counselors, teachers. So I would have those things, and sometimes kids just get bored and they just need like the support of each other. So I created these groups and they were able to share things. Like one day in group I had them talk about, like they wanted to talk about their crushes. Like I met them where they were, you know, like we do in therapy, and I just let them be themselves. And I was kind of like, maybe, according to the kids, I was like their mother, their grandmother at the school. And then I got to know all the parents. I was literally the one that would open the gates in the mornings, a mental health professional open the gates, right? So, so in each school, there is a person like that. I think for elementary schools, you have one mental health professional. Middle and high school, there's at least 2 to 3. And they can do things to, you know, help your kid. So that's extra support. And they can be the guiding force in what services that kid get in each school, as well as how it connects with the kids that are, you know, hospitalized or in treatment centers. Okay? So that's something that's an extra help here, and it works fabulous. It works really good.
Good to know, okay.
I work in the mental health field as well. I actually run a outpatient clinic. So we do individual therapy, family therapy, in-home therapy. So I'm here today because Dr. Hasija, we've been worked together, know each other, and I'm a big fan of her. So I'm here to support her. Also really try to understand our resources, our extraordinary women in this field, and we serve our community, we help our children and family. So many, if you go to a clinic, they all have this structure. Supervisor, on-site supervisors, and interns have their clinical supervisors. And we have a team, treatment team. So those are resources. Many times we kind of I notice patients or parents forget about that's an approach you can actually ask for. So those are many times, actually it's very powerful. And same as school, they have all the resources there. If you don't go there, specific ask, they not automatically come to you. Well, I actually have another question for all of you. Since you seem like all work in the Delta Parkway, we do refer quite some teenagers to your hospital for residential treatment. Can you describe from the person got referred and come there, do the assessment, and then they got admitted in the program, and then normally sometime their discharge can be after 3 days, normally it's a week. Right now they don't really go much longer than a week. That's, of course, you can explain, well, it's that reason. Could be clinical, could be insurance. And also, I would like to understand how our program runs, what resources integrated into the program, what this multidisciplinary team collaborate together. And once the patient discharged from the residential treatment, someone to the partial hospital program, right? Some may refer to IOP. Some may refer to the community outpatient program like us for continue their therapy and their medication if they have a medication already started. So can you just give a little description of the procedure so our public may know a little more about how that runs? Thank you.
Well, and I can explain a little bit about that. So when a patient comes to us, let's say from an outpatient clinic like hers is Desert Behavioral Health, or someone sees me at my clinic, Satori Behavioral Health, if there's an issue going on which cannot be handled in the home, which means the kid is actively suicidal, they have a plan to go home and overdose on pills, cut their wrist, something extremely serious, we will refer them to the hospital. When they get to the hospital, they go through a process called intake. There is a person there that will assess the kid is this an issue that really needs hospitalization, or is this something that can be handled at home? If it's a safety issue where the parent has to constantly monitor the child 24/7, and they're saying, I'm not going to sleep tonight because I'm afraid what my kid's going to do, that's when they need a place like this. Or the child is threatening them, like, you know, when you go to sleep, I'm going to beat you up, or I'm going to hurt the younger child, and you don't feel safe. That's a reason why someone should be in the hospital. Or if they're using drugs, they're hearing voices, now they're talking to themselves. Those are reasons for hospitalization. When they go through the intake process, intake will be like, okay, this person really meets this criteria. They will admit them to the inpatient psychiatric floor. Inpatient psychiatry is someone staying in the hospital. Just like you would go to the medical hospital if you were not breathing well, or if someone had a stroke, they would admit there. Same thing with a hospital like this, except it's for psychiatric reasons. We're trying to maintain safety for that kid or the adult. First, they will rule out any medical causes of this. Once the medical cause is ruled out, they will determine, okay, this is purely psychiatric. We're going to admit them to the floor. On the floor, sleep is monitored, eating, habits are monitored, groups are started. They teach the kid coping skills. The psychiatrist is there to see, does this require medication management? Is this, some of this going to get better just by helping with medications? That will be determined in the hospital. Usually kids who come and stay at the hospital, it takes about 3 to 7 days to stabilize. Depending on the child, some may take less, some may take more. But after they're stabilized from a program like this, we step them down, which means the parent could say, well, I just want outpatient services, which is once a month or once a week therapy, which we will arrange. Or some parents may think, I need a little bit more because this kid is not currently suicidal, but still thinks about, maybe I should cut myself to relieve some anxiety. Those kind of kids will refer to the partial hospitalization program, which is usually in this town, it's about 10 days, so 2 weeks, where the child will go there from like 9 to 3, and the therapist will be there, help them with group therapy, also engage the family to establish a routine for this kid at home, and have that dialogue back and forth. Is this treatment working? We're trying to teach your kid what are their coping skills to use in a difficult time, or identify your trigger. What's your trigger? Are loud noises your trigger? Are yelling, screaming your trigger? Identifying the trigger to see, okay, what coping skill can I build on to use when I get triggered? So we will teach them that in that kind of program. Once they graduate from that program, they might decide, okay, I do want to still do this, but maybe 3 times a week, which is intensive outpatient. So I'll do this few hours in the morning or a few hours after school. I have this available to me. And if someone wants that, they can continue with that. If they don't want that, when we step them down to outpatient, which is psychiatry once a month, or psychiatry once in 3 months, depending on how that person is recommended. Medication management alone will not treat most situations. Therapy is, you need it, or this is not going to go forward.
There's a couple of LGBTQ resource centers here in Las Vegas, and if you don't have insurance, they will give you therapy once a week. You may have a different therapist on a weekly basis, but they do provide this service.
And I think someone was saying before too, it was Ogechi Musa who was saying journaling. You know, that's a good way to start your process as well. That's a cathartic process to get your headspace right until you can get some help. Okay? Yes, ma'am.
So I work at Desert Behavioral Health. We are an outpatient clinic. We do have therapy and also have medication management. So what we do is we take a lot to the patient directly from There's a Parkway, from other hospital. the patient got discharged. And because that's part of the discharge plan is connect to the next step of the treatment, right? For the either medication or therapy. And like Dr. Hasija said, therapy is very, very important. Even they already stabilized with their medication, how to continue with the medication, because when they get better, sometimes they feel, oh, I'm better, I don't need this, right? They have to understand. And also, mental health problem is very challenging, not only for ourselves, for people around us as well. I just had a Chinese family, you know, traditional Chinese family, especially older Chinese moms don't recognize this or depression or mental illness. Then that's just a lazy kid, just bad kids, just a liar.
Yeah.
Okay, that's the name you call. We use a different terminology, but we describe the same thing.
Right.
Right? And the child, you think, a threat, just by, I'm gonna kill myself, and they want something. Okay, that still doesn't mean that's not a problem, right? That's still a behavioral problem. Normal person or healthy person don't use that way to get what they want, right? I'm here to teach your child and help the family, how the child can get what she wants, is that right thing to be want, right? To want, and how to get it in an appropriate, healthy way, safe way.
And sometimes parents don't know the questions to ask. You don't know what we really do. You just don't know. You see all these people when you go to the clinics and the hospitals, and you're like, are they really helping my kid and stuff? So don't feel afraid to ask questions. Don't feel afraid. It looks like when you come to the clinics and the hospitals, we're really busy, but we're not that busy to stop and answer your questions. We're never, ever too busy to do that. Okay? If you have, your questions are important. I mean, and if we have to explain the whole process over and over again, we will do it. Okay? We will do it.
I have a question on the relationship in general. Yeah, sorry. I know you're running. So I have a question about diagnosis, and especially with nowadays, 2022, mental health is in the limelight, right? And I'm curious, even with children and young adults and older adults, like diagnosing, like that whole process, how, because I mean, I think officially there's not like a clear test to be given to say, oh, that's an anxious brain, oh, that's a depressed brain. Like how is that process? You know, like how do you deal with it being more so like, what is it, the placebo effect? Like how you might be imposing these symptoms because it's so much out here, you know, and you might just fall into this behavior and diagnose yourself in a way. I don't know if you understand what I mean, but like how, you know, like how can you, how have you encountered that before, or how can we combat that? Like how do we know when it's the diagnosis, I guess?
Stay off the internet.
Yeah, so we do get, so when you're diagnosed, we just don't get these diagnoses from what we think. Right. We actually are trained and we go through a number of classes to work up to that point where you can diagnose. But we actually use the DSM. It is like a book that we look at, and that's where all the diagnoses are in the book, and we get it from there. But there's a number of things that go into diagnosing, like culture is considered, a lot of your history is considered. There's a lot of different things that kind of go into diagnosing.
Yeah.
So
you have to look at the whole picture. I think that, you know, history is very important. Some people might have a genetic condition contributing to them being a certain way. So we look into that. A lot of it, if it's just situational, that's not really a diagnosis. That's more like an adjustment period for someone. If someone passed away and someone's grieving, they're stressed out for a long time, that's not a diagnosis. It's like it's a hard period, they're grieving. You know, a diagnosis is something that impairs you functionally on a daily level, meaning it causes problems with your relationships, with your work, with your health. That would be a diagnosis that a clinician would work up to. So a careful history, I would say, is very important, even saying someone has a diagnosis. So we don't throw that out randomly. If, you know, for example, during the COVID time, a lot of people got very depressed and anxious at home, but they may not necessarily have a diagnosis. Now, if they're laying in bed, they're crying all the time, and it's been going on for months, they're not able to get up, take a shower, they're not eating, they're so depressed that they don't want to go to the kitchen to even make a sandwich. You know, we look into that and explore that a lot more before we say, okay, you have major depression right now. So it does have to be explored in detail, the contributing factors to it.
And there are also certain assessments that we can do as well that kind of help us in guiding us towards a diagnosis for you. So there's things like the Beck Depression Inventory, which is a self-reported skill that we can give to you to kind of determine whether or not you might be dealing with depression. There's anxiety skills that we can give also. For me, primarily, when a patient comes in and I'm assessing them for a diagnosis, I look at 3 things specifically: the frequency of the symptoms, the intensity of the symptoms, and the duration of the symptoms. So what are you experiencing? How long? How much is it impacting you? So the way Dr. C just said, you know, you might not want to get out of bed, you might not be eating, but is this just like a one-day thing because you're hungover, so you lay in bed all day and you didn't eat dinner, you know, or is this something that's been going on for weeks on end, and now, you know, we've got the frequency, we've got the intensity, and we've got the duration, so we can give you a diagnosis of depression. So a whole lot of things go into it. I know sometimes it just seems like, oh, everywhere I go, they say I'm bipolar, or that I have borderline, and it's because you're exhibiting certain symptoms, you're meeting the duration for those symptoms, the intensity for those symptoms, and that's why you might keep getting that diagnosis. So at some point, you might want to sit down and, yeah, that might be it.
Someone was saying before, they were like, oh, I don't know what ice cream I want, I don't know if I want chocolate or vanilla, and the friend says, oh, you're so bipolar. You know, so yeah.
No, that's not bipolar.
So if we can get into marriage now. Okay, so I have learned through doing this program that couples counseling is super important, but first you need to deal with you. So before I can go to therapy with my husband, I have to first understand what I'm doing, right? So if I were to go to therapy first without working on myself, oh, you better believe I'm going to be sitting there blaming him for everything because I'm right? So, and vice versa. So it's super important to make sure that you're dealing with your stuff first so that you can be present for that other person to see change. Okay, I want to revisit that you have the choice when it comes to who you want to be your therapist. And as I said, one of my requirements was in starting that I had to have a black female for me. Then I realized I don't need a black female. I just need somebody who knows what they're doing. But if the process to get what you need starts with a black woman, let's say, because I hear that a lot in Las Vegas, I'm looking for a black therapist. There are many here. Here's 2. You know, 2 showed up today. There are women of color here who are able to help. And I know they can be tough to find. But as I said, you can ask your insurance provider, and they will do a search for you. And they do let you ask by race if that's your choice. But please understand, your help may not be in the same culture or the same color, okay? And you have the choice to ditch one and get another one as well.
It's sometimes good, sometimes really good you have someone that not from your culture. I have some clients that, oh,
I'm not a black woman, I'm not a white woman. That's real, I'm everything. So I wasn't born in this country as well. So I got my majority of my more education. I lived here for over 20 years. So who I am, I feel I'm a mix of everything. That's how I see myself. So of course, when I come in, I say I speak Chinglish. If you don't understand, don't be surprised because it's a different language. So really? That's a joke, but anyway, so it's because you see, we talk about my hands, right? From your perspective, you see exactly what you see. From my perspective, what I see, they both true.
Right.
But sometimes therapists really bring our clients able to see both sides and able to have that freedom to view things in a holistic way. And not only consider me, also consider other, but not only consider other, also there's me, right? Finding that balance, everything is about the balance. So, and I think some of the Eastern wisdom, right, especially nowadays in therapy talk so much about mindfulness. That's the root actually from the Eastern culture. And the Western, being independent, right, being 18, you can move out of the house. When I talked to my mom about my son being 17 and go work in a fast food store, right, high schooler, making some money to pay her own gas. My mom said, why do you do that? Do you need money? He should study. He should go to some college. And I have to really, you see the differences. I said, that's a popular thing. Be proud of being 17, able to work, make money for themselves. It's not because we really I don't have the money to. But Chinese, when I went to school, when I was in school in China, I went to school 7, I got home 7, eat a dinner, continue to do my homework, everything until 11 or 12. That's our norm, right? So culture-wise, where you find your niche. So that's what I'm saying, we're back to the topic. And you're able to find someone different, right? It's so much just like open door. You really don't know what you're gonna see, but you will find something. That openness is part of a mental health component, I believe. So don't be hesitate. If they assign me to you, don't just say no because I'm not black. All right, thank you.
I'm saying when you're seeking for something that you want, you can do that. Okay.
Right, you know, and because there is still such a big stigma with regard to mental health in our underserved populations, you know, and just some of the fear that some of us have about, you know, when you look at, not necessarily mental health, but when you just look at healthcare issues, you know, across the times and just things that happen to certain populations that didn't happen to other populations, test here, test there, there's a lot of apprehension, right? A lot of apprehensiveness about going to sit before a person who doesn't necessarily look like you and that you may think might not be able to bond with you in a way where they understand some of your background and where you're coming from with certain things. So if it feels more important to you to have somebody who looks like you that's sitting across from you to get you into therapy and get you into that level of care, then please, you know, seek that person out. But do realize, you know, the person sitting next to you that don't look like you may be just as great, maybe even better in helping you through whatever your particular situation is.
Therapy and referrals to the insurance companies. When you guys bill, what is the EAP program? Like, say you get a referral from Cigna and you get an email saying that you're an 18-year-old female, you know, for regular counseling. Is that considered? Is that a specific code through EAP? I guess where do we decide? When do we know if it's EAP versus just a regular referral?
And what is EAP? What is that?
So, yeah, I'm sorry. The EAP is an employee assistance program that a lot of employers offer that gives you access to a number of mental health sessions, therapy sessions that are actually covered by your employer. So it doesn't even have anything to do necessarily with your insurance. But generally, what I've seen happen, at least for me, is just like you said, I'll get that email from Cigna, oh, we have this person, they want to use their EAP plan, you know, she's 18 years old, she's suffering from depression, let us know when your next available slot is, right? And so I respond. And then normally what happens is if Cigna's approving it and, you know, I say I have a spot open and Cigna's okay with it, they'll normally provide me with a billing code that I utilize, I put into their system, or I put it on the C1500, the CMS 1500, which is the paper form that we use to reimburse back. And I'll put that code in there and the dates of the session, how long those sessions ran. Sometimes they'll come back and ask for just kind of a clinical update, like, are they doing better? Do you think they're going to need more sessions? So that they can give an additional approval. But generally, yeah, everything's a code usually with insurance, and so, you know, if we're not billing the right code, then we don't get paid as clinicians, but, you know, you got your service, and so that's the important piece, right? Did you get what you needed when you came in to see it?
Any questions about relationships?
What's the best way to approach your spouse, in my case my wife, if I know that we need therapy? Would it offend her if I say we have to go? Or would you have any idea? I mean, slowly how to, you know, kind of pet her? That's my question. Or just say it straight out that we need to go to therapy.
Well,
That's a great question.
of course, be as soft and kind. When timing is everything, you know, timing is everything, and to have that conversation.
Thank you.
I don't think there's it's not really one way that you can do that. Just say timing and place is everything. When remember, you're going to therapy. Although you're a couple, you're still going to therapy for yourself. Okay, that's a good approach to take. Because lots of times couples will start therapy together, but they won't finish, right? So the ultimate goal is that you're coming to therapy, you want to share the whole experience and work on issues with another person, but you're ultimately there for yourself. That way that you gain insight and awareness to how you relate to the other person, not how the other person necessarily relates to you. You can get into that point, but just remember you're going for yourself.
Well, I want to thank you ladies again for being here. Dr. Gwendolyn Green, Dr. Hasija, and Dr. Cook, Althea Cook. I also want to give a special thanks to Mark Thomas of Sluggin' the Magazine, who is our proud sponsor of this event, and it's where I am. Also a special shout out to Kelly. I don't know her last name, but she is a part of the magazine as well. And I want to thank her for being here personally to attend this conference. Also want to give a shout out to family and friends who are in support of this. And I also want to give a special super duper thanks to all of the supporters from all across the nation for this Women Empowerment Conference. Thank you for donating tickets for women to be a part of this. And if they didn't catch it here live, we will have it recorded and available to them in the future. All right? So thank you. I was Audrey Pollard. It's where I am.